Back in 1999, a couple of guys coined the phrase the disability paradox. And basically what the paradox is that disabled persons who are asked to evaluate their own quality of life rate their quality of life as being quite high, sometimes even excellent. Whereas if you ask a non-disabled person to rate the quality of life of a disabled person, they tend to rate their quality of life as being quite low. And so this is a really well-documented phenomenon, and I wanted to look into the why, or what might play into that, and how sort of the underlying bias that seems to be present in that discrepancy might play also into the decision-making, the kinds of information that we talk about when we do a quality of life assessment, and the kinds of options that are proposed to families. So what I found was there's some run-of-the-mill obvious explanations for the disability paradox. It could be just negative bias about disabled persons. It can be just a divergence in the assessment of the quality of life of someone with a disability versus someone without a disability. And it can just also be a lack of understanding about the values at play and why a disabled person might rate themselves as being enjoying a really good quality of life. But when going deeper than that and looking into some studies about how anybody makes decisions in the context of disability, what I found were some psychological phenomena that also can contribute to that paradox. So one of them was framing, which is the way that the problem is presented. So what has been studied and found is that when you present things sort of in a negative way, the chances of patients choosing that is much lower than when they're presented in a positive way. And there's all sorts of studies that have been done on this. Another psychological phenomena that I talked about this morning was a focusing illusion, which is sort of a tendency, it's a human tendency that we all have to sort of focus on how things will change and what would be negative, as opposed to focusing on all the things that might not change. And so in the context of disability, if you only focus on the things that are going to be negatively influenced, that can really play or have a big impact on the kind of decision that you might end up making. And the last thing is forecasting, which is our ability to predict, our ability to adapt emotionally to living with a disability. And it's been shown that if you ask people to consider what kind of adaptive strategies they've used in the past or that they might have access to, that they then will estimate that their quality of life may in fact be higher than they initially thought in the context of disability. But I think that one of the underlying things that I find really interesting is the idea that it comes from narrative ethics. So everyone is a storyteller. Storytelling is a very integral part of human interaction and human relationships. And everyone who tells a story tells it from their own particular perspective. And so going along with that perspective, there will be things that they will prioritize in the story as being really, really vital to the story, where a different storyteller might pick up on a different thread and might go sort of in a different direction, and the story might look quite different from one person to the next who's telling it. So I think what I was trying to highlight for the clinicians is that when you present information from a clinical perspective, which is of course the perspective that they're coming from, you have to be careful if there is an alternative perspective that's equally important for the patient or family to understand, to be able to make an actually informed decision. It's also important to share that there are other perspectives out there. So when you come from your clinical perspective, it might be an important thing to say, for example, that, by the way, even though there will be certain physical limitations, people with these physical limitations rate their own quality of life as being quite high, and they find ways to adapt to it emotionally, and they're actually quite satisfied with their abilities and their quality of life, even in this context. And that's an important part of the puzzle, because if you only get, they won't be able to walk, they won't be able to go to school, they won't be able to talk, that sort of leads you in a particular direction, when in fact the disabled people who maybe can't walk or maybe can't talk or maybe can't go to a regular school feel that they nonetheless have value and that they enjoy a good quality of life, and there's things that they're contributing. So that's an important perspective. A little bit of my studies looked at a little bit at feminist ethics, and they have sort of a different approach to all of this, which I really like. But one of the things that I studied a little bit about is feminist epistemology, which is sort of the question about what knowledge is valuable, right? So when you come from a scientific background, scientific knowledge is valuable. The kind of knowledge that you get from studying and reproducing results and publishing them in scientific journals. But a feminist epistemology would also say that the kind of knowledge that you have from living an embodied experience is knowledge, and it's very important knowledge, and it deserves the same degree of respect as, you know, the knowledge that you get from doing studies and scientific investigations. It's a different kind of knowledge, but it's equally valid knowledge, and you can't discredit it just because it's embodied or self-reported. Quality of life, in some way or another, underlies almost every goal of any medical therapy that we offer, right? We do things to benefit patients. We don't do things just for the fun of it. So either it's to cure, it's to maintain function, for example, to alleviate pain or suffering. All of those things are very closely tied to quality of life. So really, any medical treatment, the underlying goal is going to have something to do with quality of life. And so those assessments come into play in almost every aspect of medical decision making. Now, a lot of it is sort of obvious in some ways. You have pneumonia, you take antibiotics, you'll feel better, you'll be cured. You may have a tummy ache from the antibiotics, but it's for 7 days, and that risk-benefit analysis is pretty obvious, and the quality of life and the improvement in the quality of life is obvious because it's the chance of cure with a minimally burdensome treatment for, say, 7 days. And the other thing, too, is that treatment decisions often hinge on quality of life assessments. So when you assess that a patient truly is, for example, at the end of life and truly is suffering, it may be ethically permissible to say that certain treatments are not really appropriate anymore because you're prolonging suffering and you're prolonging the dying process, but you really are not going to benefit the patient in terms of cure or alleviation of pain and suffering. So it comes really into every kind of a medical treatment decision that anyone might be forced to make, to varying degrees, of course. But what I was trying to highlight today is when you are looking at quality of life assessments, it's important to remember that anytime you make a surrogate assessment of someone else's quality of life, you're risking getting it wrong. And we have lots of proof of that. So you have to just be aware that there is this perspective, and you know, it's straight from the horse's mouth. Disabled people say with very great clarity that they have good quality of life, and so that has to be respected. It's not that I want to have physicians or clinicians go from one extreme to the other. I want them to be somewhere balanced in the middle where they can present that, yes, there are challenges with living with a disability. You know, this is the degree of disability that we may be talking about. And of course, it's important to remember that very, very often there is not a black and white answer, especially in the neonatal period, about what the disability will ultimately look like, how functional they will be. I mean, it's guesswork, you know, it's a best guess, it's an educated guess, but there's not necessarily any clear delineation between, you know, where there's a strict cutoff point. So I think what I was just trying to highlight is when you present the information, yes, you have to say that there's going to be challenges and there's going to be difficulties, because there will be. But at the same time, you shouldn't set it up that those difficulties or challenges are insurmountable, because in fact, people really have great adaptive capacity. I mean, that's part of being a human being. So you have to also be able to take that into consideration. And when you consider those kinds of strategies that are available that will help someone to overcome some of those challenges or deal with some of those challenges, it sort of balances out the picture. So it's not about presenting it all in the negative, and I don't think physicians set out to do that, but I think that this is where it becomes really important to talk about narrative and who's telling the story and why certain things are important and other things come across as being less important when to a different storyteller or a different listener they may pick up on very different things, right? So it's just about kind of presenting the different perspectives that should all be considered in that kind of a decision. I actually do, though, believe that it's almost impossible to adopt the perspective of someone else. So I think actually your idea of another family who, for example, has someone in their family, a child, whatever, with a disability may much more honestly represent what that entails and what that means. And I think that those are tools actually that we do use here sometimes, where we have families who have to make a difficult decision and they really want to know, well, like, I want it to be informed, I want to know what I'm getting myself into, whether I choose this or that. And we'll set up meetings with families with children with similar complications, disabilities, whatever, so that they can have that kind of a conversation. I think one of the things that one of our other speakers today hit on about kind of defining the kind of communication you want to have up front with your physician may actually go a long way towards mitigating that sort of distrust about, is the physician going to tell me everything? I think if you said up front, look, I want to make a really informed decision for my child. I want to do whatever is in my child's best interests, and I want to double check the kinds of information that you're giving me. I want to make sure that you're representing things in the way, and I want to consider what the perspective of somebody in that situation might be as well. And I think those are very reasonable things to say up front, and say, I would like help with that. Like, I would like to look into what is the life, what does it look like in this context of this particular disability or this particular limitation, and what kind of abilities will they have? Because again, in terms of the psychology, we tend to focus on what it will mean, like what they won't be able to do, what they won't have access to, as opposed to all the things that they will be able to do, right? So it's really that sort of dichotomous thinking about disability versus ability, right? So everyone is able to different degrees. This person might have a particular disability in one area, but they might have lots of great abilities in other areas. And it's important to try to keep that in mind. And that's one thing that I was trying to impress upon our clinicians today. Don't always just present things in terms of the pathological consequences. You can also talk about adaptive strategies and abilities, balancing the equation.